Hello and welcome to Everyday Medicine. I'm Dr. Luke and I'd like to thank you for joining me on this podcast series where we share conversations with colleagues, exploring their special interests in medicine and bringing insights, ideas and advice which I hope will be applicable for our medical practices. In this episode, we're talking with an expert on fecal microbial transplantation for inflammatory bowel disease. Before starting, for Australian audiences, listening does give eligibility for your CPD, so log in and add this as an activity, and you may also consider journaling, reflection, and adding to the review and performance section in your CPD. Well, the use of fecal microbiota transplantation, FMT, to treat severe C. difficile enterocolitis was visited in episode 14 of Everyday Medicine with Dr. Darcy Holt as our guest. If you haven't had an opportunity to listen to that conversation, please do. Hopefully it will pique your interest. In this episode, we invite a guest involved in active research at Melbourne St Vincent's Hospital to discuss FMT in inflammatory bowel disease broadly, then more specifically as it applies to her current research project evaluating its efficacy in Crohn's disease. Well, FMT is defined as the infusion of faeces from healthy donors into the gastrointestinal tract of recipients to treat disease-associated gut dysbiosis. Noting that the precise etiology of IBD is unknown, a multifactorial pathogenesis is proposed, influenced by genetic susceptibility, host mucosal immune responses in the environment, including diet, the gut microbiome, and smoking history. Particularly with both ulcerative colitis and Crohn's disease, a deficiency in fecal bacterium prausnitzii, recognized for its potential anti-inflammatory properties, has raised interest in the FMT space. Well, to date, FMT has been investigated in patients with inflammatory bowel disease, both in non-randomised and subsequently randomised controlled trials, showing promising results, although with significant differences in FMT protocols and procedures. The adoption of FMT for the treatment of IBD is compromised by recruitment of donors, preparation of fecal material, determination of the optimal route of administration, and lack of established regulatory framework. And establishing an optimal framework is essential for the future management of IBD should the merits of this therapy stand up to scrutiny. Well, the first International Rome Consensus Conference on Gut Microbiota and Fecal Microbiota Transplantation in Inflammatory Bowel Disease, published in Gut BMJ this year, has attempted to set this framework and is a very helpful publication. In this episode, we introduce Dr. Sasha Feely, who is actively engaged in the MIRO study looking at FMT in Crohn's inflammatory bowel disease. The MIRO study is a randomised, double-blinded, placebo-controlled trial where all recruited patients receive active standard IBD treatment, and those on placebo who don't respond are administered active FMT therapy. This is an excellent study with greatly anticipated results, and I was curious to learn more about the research directly from Sasha, so please welcome her to the podcast. Dr. Sasha Feely, thank you for coming and joining me on Everyday Medicine. It's a real pleasure to have you here. Thank you so much. It was very nice to meet you in Sydney at a recent FOLC symposium where I was very excited to hear about your study as the lead and senior gastroenterologist in the fecal microbial transplant study at St Vincent's, looking at its application in inflammatory bowel disease. So I couldn't wait to get you here as a guest to talk about that. So first of all, thank you very much. I know you're busy, you've got a young family. So if they come in, it won't matter. It doesn't matter. But I really
hopefully sleeping.
Yeah, they're sleeping, hopefully. Got husband on duties, which is good. That's how it should be. So I really appreciate you coming and chatting with me tonight. Before we talk about your research, where you think it's going, how it will be applied in medicine, can you give us a little bit about your background? Tell us about how did you get into this position?
Sure. Well, thank you for having me, Luke. It's a pleasure to chat to you tonight. So I ended up in gastroenterology as a specialty for probably a number of reasons. Initially, I had a particular interest in the public health sphere. So I thought I was heading more towards infectious diseases, but as I got engaged in some research projects with the gastroenterology unit at the Alfred Hospital, I realised that there sort of was a public health space in gastroenterology. Particularly, my interest at the time was diet focused, given that, at the moment, obesity is such a significant global burden. And I really thought that, dietary modification could be a great segue to get involved with through medicine for that reason. But then upon learning about, I guess, the variety within gastroenterology, that was really appealing to me. So I love that, multiple organs are examined. I love that we've got the whole gastrointestinal tract, but also gallbladder, pancreas, and liver. So every day seems quite variable and interesting. And then there's also variability, I guess, in day-to-day practice. So I might see a patient in clinic and then do their endoscopy and intestinal ultrasound, which is quite helpful to the therapeutic process, but also something that you don't really get to do in a number of specialties. So I guess there were a lot of reasons that gastroenterology as a specialty appealed to me.
It's very rewarding, isn't it? I totally agree with you. It's a very rewarding specialty. And
yeah, for sure.
Of course, you become the patient's advocate in relation to problems like inflammatory bowel disease, where there's a lot of trust put in the clinician. And I'd like to then now just talk about, your journey from where you have been now to where you are the lead investigator with FMT. Tell us a bit about fecal microbial transplantation. What's your interest in that?
So I guess it's pretty exciting that there's a therapeutic strategy that was first used 1,700 years ago in one of the dynasties of China, and it's re-emerged in the modern era of medicine. I'm certainly a big believer in pharmacological strategies, but we're coming to realise that it's not the only and it's not always the best strategy in all conditions, and that's particularly true of gastroenterology. Some conditions like irritable bowel syndrome, there are lots of different therapeutic avenues that we're exploring through research. So I like that this is a therapeutic strategy that is not a pharmacological strategy, and it's, old things often represent something true. And I suspect that, using a strategy to change the community of bacteria in the gut could potentially modulate a lot of different disease processes. I guess we just need to figure out which and why and how, but that's why there's a lot of research being done in this field at the moment.
How close are we to understanding the microbial, the dysbiome, if you like, that can occur in inflammatory bowel disease? Do we understand, or are we honing in on which microbes might actually be more important?
I think so. I think part of our journey is actually just developing newer techniques to explore the microbiota. So, initially bacteria was identified through culturing, which, for that we were very dependent on the culture media that we had available to grow bugs. Now we've got different techniques which combine culturing as well as shotgun metagenomic sequencing, which uses DNA to find out which bugs are present. And so I think even just that step up in our capacity to identify particular bugs down to species level gives us a better indication of what's present, not just inflammatory bowel disease, but in normal people or healthy people. So we've definitely seen some characteristic profiles in different inflammatory bowel diseases. We've been able to distinguish the microbiota of patients with Crohn's disease and ulcerative colitis compared to healthy individuals. And some of the repeated patterns we're seeing in Crohn's disease specifically are reduced presence of some anti-inflammatory bacteria and reduced diversity in the different species that are present. But, it's hard to distinguish between the different cohorts that we're examining because people are using, different research groups use strategies to do the testing. So it's hard to compare the results that we have, but we're definitely seeing particular signals that are repeated time and time again on the different between the different groups.
This is the vanguard. You're at the vanguard of all this, and so it's it's a learning curve for everybody. But we've got different phenotypes of Crohn's, of course. We've got different presentations of ulcerative colitis with left colonic disease or rectal disease or pancreatic disease. Do we know whether there are differences that reflect those sorts of patterns of illness, or is it too early for us to be able to sort of make any clear distinctions and comments?
I don't think in the literature we've been able to distinguish between the different phenotypes just yet, but I suspect we will. Certainly there are phenotypes that I suspect will respond to microbiota modulation more than others, and even within Crohn's disease, we know that there's a greater bacterial load in certain areas of the intestine, and maybe those are the patients with those areas affected might respond better. But I think just more research will need to be done. We're still pretty early days in identifying which bugs are even abnormal in which condition.
Tell us a bit about your study. What is happening at St Vincent's? But what's the base, the premise of it, and how you conduct it?
So I'm conducting the Microbial Restoration in Inflammatory Bowel Diseases trial. It's a large double-blind placebo-controlled trial. We've only included patients with Crohn's disease for this study, and that's because our same group, the CAM research group, has already conducted a study looking at fecal transplantation in ulcerative colitis, and our other collaborators in Adelaide also conducted one of the other landmark trials in ulcerative colitis, both of which did show good results, which has led us to now conducting a similar trial in patients with Crohn's disease, whereby patients with active inflammation on the basis of their symptoms and also more objective measures like their endoscopy or their ultrasound findings, and they, depending on where their location of disease is, determines how we administer the fecal transplantation. So if patients have their upper gastrointestinal tract involved, then we would administer the fecal transplant via gastroscopy. If they've got very distal, lower down disease near their rectum, then we might give a combination of colonoscopy plus enema administration over that time. We'll do an induction phase, which is sort of the quick phase to get them better over the first 8 weeks, which is quite intensive. And then if they do well, we keep them in the study for the remainder of the year, which is considered our maintenance phase. And then after that, the plan is to do extensive scientific work to determine which bacteria or other organisms, fungi and viruses we plan to evaluate as well, which organisms engrafted were associated with a response or a lack of response to the FMT. So we can try to delineate what's actually driving their response, because FMT contains everything. It contains the organism, the byproducts, this complex ecosystem. We want to know what's actually driving the benefit or the lack of benefit in these patients.
There's a whole lot to sort out there, isn't there? A huge amount to sort out. Can you explain the practicalities of FMT? You've got donors who are coming from. Are they from South Australia? Am I right about that? Or you're not?
That's
sick?
right. Yeah. That's right.
Away from Berwick and Harkaway. So they're coming from South Australia. How are they chosen in South Australia? What is that process?
So it's surprising to hear, I suspect, that it's quite difficult to become a stool donor.
Yes.
Out of the people who put their hand up, only about 5% get through, and that's because it's quite a stringent screening process. They have their history taken to determine any medical conditions they have themselves, also to determine if they have any family history of particular medical conditions through animal studies have shown can actually be passed on to the recipients. They also get their blood tested, their stool samples tested, and then it gets quarantined for 3 months and then tested again. And really the things that are being tested for on blood and stool is whether they have any chronic infections or antibiotic-resistant bacteria, because we wouldn't want to be giving that to another person. And then once they've sort of met the criteria, they donate the stool as frequently, I guess, as they can. The stool gets filtered down several times. In Adelaide specifically, where we get it from, it's called Biobank, they process the stool through a technique that is anaerobic, which means the oxygen-sensitive species don't get killed off in that process. And we suspect that's pretty important for Crohn's disease. So that's one of the reasons why we've obtained our stool from this particular stool bank. And then it gets frozen and shipped around the country for use.
Yeah, that's also very, very complicated. Is that the same stool that you would use to manage someone with Clostridium difficile enterocolitis that had reached a point of maybe no return?
Yes, absolutely. The Biobank stool is used predominantly for Clostridium difficile infection. And
in the study that you're conducting with Crohn's disease, are you applying from the Biobank? You're applying that donor. It's a probiotic, really. Are you providing that on one occasion, 3 occasions? How many occasions will you apply that?
So it depends on the mode of administration, but for the patients who are in the upper gastrointestinal delivery group, they'll get it 3 times in the first 8 weeks. And then for the remainder of the year, if they enter the maintenance phase, it's every 2 months for 44 weeks. Whereas in the lower gastrointestinal delivery, we give one administration via colonoscopy, which is a larger dose, and then they self-administer at home enemas weekly for the induction phase, followed by every 4 weeks in the maintenance phase. So it's quite intensive dosing.
It's very intensive, isn't it? And are you applying, it depends where the disease is, I guess, but are you applying it at colonoscopy into the ileum? Or
That's right.
into the ileum.
That's right, colonoscopy into the ileum. And then for the gastroscopic delivery, we use a pediatric colonoscope to enable us to get further into the small bowel so we can administer it directly into the jejunum, the second part of the small intestines.
Have there been, so there are practical problems there with the application with the patients getting the biobank? We fortunately have that with the group in Adelaide that you mentioned. Are there any other complications or difficulties that you've observed in terms of, be it provided proximally or distally? Are there any major issues that patients should know about or doctors should know about if they're referring patients into you?
I suppose every procedure has an inherent risk in terms of the anaesthetic administration and the procedure itself, albeit a very low risk. Okay. The risk we worry about with gastroscopic administration is a low but significant risk, and that is of aspiration pneumonia. In order to combat this, we've got several measures in place really to mitigate this risk. So we actually do the procedures sitting up completely, and we only give a very low volume via gastroscopy compared to the colonoscopy. We give a medication to help empty the stomach, and patients, stay upright for the entire hour following the procedure without food ingestion. So we've taken a few measures, and so far haven't had any risks, which I suspect we won't, because the trials that did have complications similar to that were trials that used high volume.
Were they delivering also, or are you delivering into the distal duodenum, or are you trying to get even a little bit further down if you can?
So we're actually, we administer it into the jejunum. The trials that were conducted before us that were complicated wouldn't have been delivering the stool
do you think,
as deep as we are.
Do you think there's a way of producing what you're doing for the biobank that you could grow that same sort of microbiome in the laboratory? Is that one of the objectives that you're hoping you might be able to do this in a more sort of organised synthetic way somewhere, rather than, because it's quite difficult getting those stool samples. That must be very labour intensive.
Yes, absolutely.
That's one of your objectives perhaps down the track, once you know which microbes ought to be provided. Yeah, absolutely. So I think that's where all this research is heading, really, a personalised microbial therapeutic approach. Yes.
But like I said at the start, it's this complex ecosystem. We're not entirely sure of what is normal, what is pathogenic, what is driving disease, what is driving response. And that's why so much research will need to be done prior to those strategies being developed. I mean, certainly in Clostridium difficile infection, we've got a better understanding of the pathogenesis of the condition and what's driving the therapeutic response to this treatment. So there is a company that is at the moment trying to develop a product that is a combination of a few bacteria or spores. It was another product, neither of which have actually resulted in good enough results just yet. But I mean, that's where we're headed, and I suspect we will get there.
Have you had any identical twins where one's had Crohn's and one hasn't? Have you had a chance to have such a wonderful patient cohort?
Wouldn't that be fabulous? We haven't had any twins referred yet.
Not yet. I'll look out for you. Are there any other sort of biomarkers that you think might be helpful in determining who could benefit from this therapy? Like, your study's going to give us a lot of information, and you'll be drilling down into that data. But is there a thought of any particular biomarker at this stage that might help, or any particular phenotype, for example, in Crohn's, that you think might be an indication that that's the group that we ought to be thinking about? They're the ones that really do seem to benefit. Could it be ideal Crohn's, or could it be more chronic Crohn's, or whatever, fistulizing? Do you have any information about that, or is that still way too early for us to make any comments about?
Oh, it's definitely way too early to say which phenotype responds, but we suspect that it may not just be a bacterial composition or element of their microbiome that's driving response or lack of response. I suspect it's not actually just one thing, not one thing that's deficient in their microbiota that needs to be fixed, and not one thing that needs to be administered to fix their condition. I suspect it's maybe a group of bacteria that have synergistic properties, as well as the presence of their metabolites that may have anti-inflammatory components or contribute to the host immune system. And the other part of that is, just because viruses and fungi are low prevalence doesn't mean that they're particularly important. I think we've got this prejudice towards bacteria because they're easy to identify because of their abundance, but maybe these low prevalent microorganisms are also significant.
They might be the true villains. If you have an inflammatory surface, you're going to get a change in the bacteria. So there's a chicken and egg argument too. And often I find when patients have inflammatory bowel disease, one of the first things I'll say is, I've got a bit of a change in odour of the material coming through and they're passing as gas is a bit different. And I've often wondered whether it was more that there was inflammation that developed and then that has changed the environment for the microbes. It's become a less habitable environment, so you're getting different sorts of bacteria there. So I'm going to be interested to see your study when it comes out to work out chicken and egg. You had an interest in diet very early on. Has your group been looking at that as well in terms of how the diet? We hear a lot about prebiotics, and I'm sceptical about lots of these things. But have we had any information about how diet might change the microbiome in a favourable way? Do we know anything about that, or is that not really part of your sort of brief?
No, it is. A research group have two big trials going. One is a collaboration with Hong Kong, actually, where it's called the Enigma trial, where there's a really large cohort of Australians, participants from Hong Kong, as well as the US, which have done lots of microbiota studies evaluating the microbiome changes associated with particular modifications, as well as dietary exposures throughout childhood, and have found particular associations with the development of Crohn's disease, such as excess soft drink exposure at younger than 10 years old, antibiotic exposure, things like that. And then there's the other trial called the Delectable trial, where patients from Melbourne were given either a whole foods diet largely focused around ulcerative colitis, and then another whole foods diet without preservatives for Crohn's disease. And initially the intent was to evaluate compliance, and now that that's been shown to be quite, that patients have been able to be compliant to these diets, now there'll be a more personalised approach in the next phase of this study. But, we're very hopeful about the capacity of dietary modification in these conditions. It only makes sense that if there's microbiota driving the inflammation, that modulation with therapy can improve some of the inflammation that's there.
It's sort of a more holistic approach, isn't it? It's just looking beyond just the pharmacology. There have been a Rome consensus, a series of Rome consensus statements recently published, which I've read, in which there is still the comment, we don't have enough information to support the use of FMT in inflammatory bowel disease. And they're more specifically talking about UC and Crohn's disease. Well, we're waiting for studies like yours to come through. Where do you think we have FMT for C. difficile? Okay, this is absolutely confirmed. We have people that are giving FMT outside the remit of their usual medical practices, and we're not sure that that's actually correct, but there you are, that happens. Where do you see this going? What's your gut feeling about, where we're going to end up with FMT?
I think there's a place for it, not just because of potential efficacy, but also because, we're comparing this therapeutic strategy with immunosuppression, which a lot of patients don't want. And, they don't want the complications, and often, they don't want, these unwanted side effects. So in my eyes, I think it'll be a therapeutic strategy with a better side effect profile. And my point of view is that the ulcerative colitis data is good. There have been 6 randomized controlled trials that have shown efficacy. The response rates are similar to that of some of the advanced therapies that are available and are used every day. I think there's a general reluctance to use fecal transplantation, maybe just because it's novel and we just need to develop more experience with it. It's a positive step that TGA have gotten on board and are regulating the manufacturing and the process to ensure that it's safe and transported and then delivered in an appropriate fashion. And I suspect that sort of the first step towards increasing acceptability of use within Australia at least. But I think there's a general reluctance and maybe just more research needs to confirm its efficacy before people are more willing to use it. But I think patients definitely want to use it, at least try it.
Well, I think, we're really grateful to you and your team for, for conducting the studies and perhaps bringing the information and the truth to the practice of medicine. And what would be really lovely is if we could at some point down the track re-interview you when you have some more data and information, and all the tangled web of information has been untangled, and we can look and see what this is leading us to. So really grateful for what you're doing and your time today and your research. I'm going to ask you a non-medical question now. Thank you very much.
Sure.
So I think you're a foodie, Sasha. I think, am I right? You look like you know where to dine. So for people in Melbourne, give me your top three restaurants. Where should people?
That's a tricky question.
You're in the heart of sort of like you're around Brunswick there, aren't you? In the heart of restaurant, the capital.
Oh, that's true. Well, I work there. So, I mean, I guess a favourite is Marion, which is right next to St. Vincent's. That's pretty delicious. Can't go past a prawn roll. And where else is delicious? Freddy's on Chapel Street, lovely Italian.
Okay.
Low key.
I'm writing this down. Okay.
Low key, good food. And I guess Kizime in the city, amazing Japanese.
I got to write that down. That's going to be at the top of this podcast. Dining. Sasha, thank you so much.
Embarrassing.
Thank you so much for taking the time to talk to me. And I really do wish you well and the whole team there at St. Vincent's. And we'll look forward to hearing more about the outcome.
Thank you. That sounds great. Thanks for your time.
Thank you.
I'd like to thank you for joining me in this conversation with Dr. Sasha Faecal. I hope you enjoyed it as much as I did. I think FMT clearly holds great interest and promise, with some important work ahead to guide protocols and a more targeted and nuanced approach based perhaps on patient phenotype and microbiome composition. But I'm sure we'll be hearing more exciting news and developments from Dr. Faecal as soon, and we wish her and her team great success. Well, next week we'll be interviewing another guest, and we welcome you then. During the podcast series, we cover a wide range of topics across many specialty interests. The discussions are not intended as specific medical advice for patients, but as general information only, and reflect the opinions of the guests interviewed. Requests for new topics to be reviewed and comments about the conversation you've listened to are welcomed, and may be emailed to manager@gihealth.com.au. Thank you.